Hey y'all, Dr. Sean Tassone here, America's Holistic Gynecologist. And I wanted to take a couple of episodes here and talk about this group called the North American Menopause Society, or NAMS. And the reason I want to do this is because I've been getting a lot of questions lately regarding NAMS and their statements. They have a position statement that they come out every year or two. And it's kind of the group, for some reason, which I will talk about maybe in a future podcast next week, that a lot of doctors will go by. Now, as you know, physicians as a group tend to be herd animals. They don't really venture outside the box for fear of, I don't know. I think that there's this fear that if you practice outside of the norm, not the standard of care, that's different, but what other physicians in the community would consider the norm, that you're somehow committing some egregious error to even think outside the box, to even consider other options than what the status quo tells you to do could sometimes be, you know, not good. And so I think it's good to look at why. There's two things. One is a lot of women are told by doctors like Mary Claire Haver, who, she's a board certified OBGYN just like me. And she will tell women to go search the North American Menopause Society for a NAMS certified practitioner. And I would disagree. I don't think it's necessarily bad advice, but I don't think it's the end all be all, because a lot of NAMS providers, one, are horrible. Two, they are rude. And three, they don't necessarily do anything other than what they're told. And the question is this: any OBGYN, first of all, that has to be NAMS certified, you have to ask yourself why. Why would they pay to become NAMS certified when they're already a board certified OBGYN? It doesn't make sense to me. We have plenty of knowledge. We don't need to pay the extra $1,000 a year to learn how to prescribe hormones. That's just ridiculous. I can see other people like an ER doctor that wants to learn how to do hormones. And even for them, what they're doing is they're becoming NAMS certified to use it as a marketing tool. It's a marketing tool, people. Really, it is. It doesn't mean that they know what they're doing. Maybe they took a few extra courses and they passed a test. That's what it means. It doesn't mean that they know how to put it into practice. It doesn't mean that they do anything that they're told. And I did an Instagram post a while back as to where NAMS gets its funding, and this is on their own website. And it's your typical people. It's Bayer, it's Pfizer, it's Astellas, it's PharmaVita, it's all these big pharmacy companies, and even now a smattering of companies like Bonafide, who just sold for like hundreds of millions of dollars to a big pharmaceutical company out of Japan. So they're getting all of their funding from big pharma. Who do you think they're going to push you towards? Now, that's not to say that it's a mindless organization and that's all that they do is toe the line. But come on, if they're receiving funding from big pharmacy, where do you think they're going to push their people? And that's why NAMS, and we'll talk about this in this episode, because what I want to talk about today is the NAMS 2022 hormone therapy position statement. And I also want to talk about their 2023 non-hormonal meno or menopause statement on non-hormonal issue. And then I want to go through the patient flyer that they have on their website. So initially, let's talk about their 2022 hormone therapy position statement. And it basically reads as this: the 2022 hormone therapy statement of the North American Menopause Society updates the 2017 hormone therapy position statement. So they didn't even update it for 5 years. Okay, to me, that's an issue. And identifies future research needs. An advisory panel of clinicians, we'll go over who they were later, and researchers expert in the field of women's health and menopause. Basically, that's going to mean that they were people probably from Ivy League schools, Harvard, the whole 9 yards. Doesn't mean, again, that they, and I'm going to dig into see if they were funded by big pharmacy as well, because many of these academicians are. An advisory panel of clinicians and researchers expert in the field of women's health and menopause was recruited by NAMS. Okay, so you have an organization that's putting out a position statement. And don't tell me that they don't already have a lot of octopuses in their system as far as interventions from these pharmaceutical companies. They're the ones that are recruiting the clinicians. Okay. We basically recruited our own clinicians to review the 2017 position statement, evaluate new literature, which literature did they choose, assess the evidence, which evidence did they choose, and each consensus on recommendations using the level of evidence that they saw fit to identify the strength of recommendations and the quality of the evidence. The advisory panel's recommendations were reviewed and approved by NAMS. So NAMS chose the clinicians. NAMS then had to approve what they said. What the hell? Hormone therapy remains the most effective treatment for vasomotor symptoms. Again, the whole point of hormone replacement therapy initially, when it came out, was for vasomotor symptoms. Years ago, like 20 freaking years ago, when I was a resident, longer. I don't even want to talk about how long ago that was, but it hasn't changed. This is still what they're focusing on. And the genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. Well, that's pretty damn important. The risks of hormone therapy differ depending on type, dose, duration, use, route of administration, timing of initiation, and whether progestogens are used. Good. Glad they put that in there. Treatment should be individualized using the best available evidence to maximize benefits and minimize risks. Agreed. With periodic reevaluation of the benefits and risks of continuing therapy. Totally agree. For women aged younger than 60 who are within 10 years of menopause onset and have no contraindications, the benefit to risk ratio is favorable for the treatment of bothersome vasomotor symptoms. So basically, they only recommend it if you have hot flashes or osteopenia. They're not talking about insomnia, sex. They're not talking about energy levels. They're not talking about mood. They're not talking about any of the good stuff. Just hot flashes and vaginal dryness. Because obviously that's what women are, is y'all are just a bunch of hot flashes and dry vaginas, according to North American Menopause Society. For women who initiate hormone therapy more than 10 years from menopause onset or who are aged older than 60, the benefit risk ratio appears less favorable. Now, they're not saying contraindicated, they're saying less favorable because of the greater risks of coronary heart disease, stroke, venous thromboembolism, and dementia. The dementia thing is highly debatable. The cardiovascular risks are there. And the reason for the cardiovascular and stroke risk is because if a woman who hasn't been on estrogen, and it's only the estrogen part, for more than 10 years, and she has calcifications in her coronary vessels, the estrogen can soften those calcifications and cause them to embolize, causing a potential heart attack. Now, the risks are small, but they're there. If I have women in that age group, I discuss this with them. And I also discuss that maybe they should go and get a preventative cardiovascular CT calcium score. And if you have a lot of calcium in your heart, yeah, maybe you want to talk about it. However, we also know that estrogen can lower bad cholesterol. It can raise good cholesterol, and it's good for heart health. So it's catch-22. They also say that longer durations of therapy should be documented for indications such as persistent hot flashes, because again, that's all you are, is a hot flash, with shared decision-making and periodic evaluation, which means if you're going to do it longer than 10 years, talk to your doctor about it, see how you feel, and if you think it's good for you, then let's talk about it. For bothersome genitourinary syndromes of menopause symptoms not relieved with over-the-counter therapies, women with indications for the use of systemic hormone therapy or low-dose vaginal estrogen therapy or other therapies, vaginal DHEA or oral ospremifene are recommended. Okay. So that in and of itself is the overall nutshell. Basically, what they said was, it's good stuff, but they're only limiting to vasomotor symptoms and genitourinary symptoms, meaning hot flashes, vaginal dryness, maybe painful intercourse, and it can prevent bone loss. They really don't give it a whole lot much more than that. So what they did, how did they come to this? Well, they had an advisory panel of clinicians and expert researchers. We've already talked about this, and they reviewed the 2017 statement from 5 years ago. NAMS acknowledges that no single trial findings can be extrapolated to all women. So they're saying hey, we looked at some literature and we realized it doesn't apply to everybody, but this is for a collective. The Women's Health Initiative is the largest randomized controlled trial of hormonal therapy in women aged 50 to 79. And its findings were given prominent consideration. That to me is a red flag. We know that the Women's Health Initiative has been debunked. We know that the authors of the WHI have retracted a ton of what they stated. It only studied Premarin, Prempro, and placebo. We know that the Premarin only arm of the WHI was not discontinued. It was the Prempro arm, meaning the equilin, the horse estrogen combined with a progestogen. These are not bioidentical hormones. It's kind of like comparing grapefruits to oranges. They might sound similar and they might even look similar, but they're not the same thing. And I don't think they should be using it. And actually, when they say women aged 50 to 79, it was actually most of the women in the study were over the age of 60, and they had increased risks of breast cancer anyways, and the risks were still rather small, about 1 in 1,000. They did add a proviso. They said, however, it is important to note that the Women's Health Initiative employed just one route of administration, oral formulation of estrogen, conjugated equine estrogen, meaning horse estrogen, and only one progestogen, which is medroxyprogesterone acetate, which in my opinion is probably the worst medication ever invented in the history of women's health. With limited enrollment of women with both vasomotor symptoms or hot flashes who were aged younger than 60, meaning they said ages 50 to 79, but there weren't many women that were younger than the age of 60. Okay, so we have a study that used Prempro, Premarin, and we used a lot of women that were over the age of 60. Ridiculous, because most women over the age of 60 may not even be using hormones, but those women that are 50 to 60 may need it a lot. Then they go on to say, that they have different levels of scientific evidence, which is called level 1, level 2, level 3, blah, blah, blah. They basically then looked at the dosing of their estrogen therapy, the therapeutic goal being the most appropriate, often lowest effective dose, which I totally agree with, the smallest dose possible to give you the biggest effects. They only looked at progestogen therapies. They didn't even look at bioidentical routes. And they used basically, again, they really focus on this vasomotor symptom. They don't really focus on other things, just feeling better, energy levels, sleep, the really important stuff. They just kind of ignored. They go on to talk more about the Women's Health Initiative, which I don't know why they spent so much damn time on the Women's Health Initiative. And then they go on to talk about FDA-approved indications. So hormone therapy has been FDA approved for vasomotor symptoms. Okay, hot flashes, prevention of bone loss, premature hypoestrogenism, meaning for women who have hypogonadism, for women that have surgical menopause, for women that have premature ovarian failure, genitourinary symptoms. So this is what they focus on. They only focus on hormone replacement for hot flashes, bone loss, women with premature ovarian failure or surgical menopause, and if you have a dry vagina. And we can call it genitourinary symptoms, but it's a vaginal dryness thing. Key point, hormone therapy is FDA approved for all 4 indications: moderate to severe hot flashes, prevention of osteoporosis in postmenopausal women, treatment of hypoestrogenism caused by premature ovarian failure or surgical menopause, and the treatment of moderate to severe vaginal dryness. It's only approved for those things. So technically everything else, it's off-label. Now, they go on to talk about the evil bioidentical hormone therapy, and specifically compounded bioidentical hormone therapy. Now, compounded bioidentical hormone therapy, the hormones themselves, estradiol, progesterone, testosterone, DHEA, they are all FDA approved. The medications themselves are FDA approved. So when you hear these influencers out there saying it's not FDA approved, they're full of shit. It is FDA approved. The compounding of the hormones, meaning having them made at a compounding pharmacy that's local to you, the pharmacies aren't FDA approved because they can't FDA approve a pharmacy. But anyways, the medicines themselves are. The term bioidentical hormone therapy can be misleading. Here we go. Because there are both government approved and compounded bioidentical hormone therapies. Government approved meaning FDA-approved bioidentical hormones include estradiol, estrone, and medroxyprogesterone, or micronized progesterone, which are regulated and monitored for purity and efficacy. These are dispensed with package inserts containing extensive product information based on randomized clinical trials and may include black box warnings, blah, blah, blah. These therapies may combine multiple hormones, estradiol, estrone, estriol, DHEA, testosterone, and progesterone. This is what they're talking about with compounded stuff. And they are untested. They are unapproved combinations, meaning the FDA did not get enough money to approve them. And these are subdermal implants, pellets, or troches. But they're the same medicines that you would get at Walgreens or Walmart. They just tested for quality assurance. Compounded bioidentical hormone therapy has been prescribed or dosed on the basis of serum, salivary, or urine hormone testing. However, the use of such testing to guide hormone therapy dosing is considered unreliable because of the differences in hormone pharmacokinetics and blah, blah, blah. Okay, I get that. However, if you are good at it, if you've done it 50,000, 60,000 times like I have, then it is very good to do. Now, I've done a podcast on the different types of testing, and I would tell you that serum testing is excellent because it's what's in your blood. I'm not a big fan of saliva. It sucks. I wouldn't use it. And urine testing is good, but it's expensive. So what they basically say is patient preference for compounded bioidentical hormone therapy should be discussed. Okay, let's discuss it. Awesome. Prescribers should only consider compounded hormone therapy if women cannot tolerate a government-approved therapy for reasons such as allergies to ingredients, blah, blah, blah. So basically what they're saying is support the companies that support us because, God forbid, you have other choices. Key points. Compounded bioidentical hormone therapy presents safety concerns such as minimal government regulation. Since when, as we all saw during the last few years, since when is minimal government regulation ever a freaking issue? Actually, it kind of, in my opinion, means that it's a good thing. But anyways, they're saying it could lack sterility, lack scientific efficacy. I mean, they go on and on about it. And they say it's a level 1, meaning it is the highest importance. Okay. God forbid we have other options. God forbid they allow the doctors to decide what's good for their patients. God forbid they know that I've gone to the compounding pharmacy that I use here in Austin. They test batches. They are extremely safe. They are extremely sterile. They have everything they need. I've watched them make the hormones. They take very, very special care. Now, are there rogue pharmacies? Sure, I have no doubt. But the one that I use, because guess what? I want to use quality for my patients, and I have vetted the pharmacy. I don't just use any random pharmacies. Salivary and urine hormones testing to determine dosing are unreliable and not recommended. I might agree with that. Serum hormone testing is rarely needed. That's not true. The reason that these influencers that are NAMS certified will say that you don't have to have blood testing is because they only prescribe medications like patches, like say Vivel, which is a bioidentical hormone that you can get at Walgreens, or Prometrium, which is a bioidentical progesterone that you can get at Walgreens. The reason that they say you don't need to test is because these companies, when they went to the FDA, did the testing. So they already did the testing. So they freely admit you need to test, but they already did it, so you don't need to do it now. Well, what? Come on, man. They're talking out of both sides of their mouth. So anyways, not to belabor all this, but we went through all of the things. We talk about how they only talk about vasomotor symptoms, urinary tract symptoms, and they brought up sexual function, but only in the sense that you might need vaginal estrogen if you can't have sex. They also did barely mention sleep disturbances that they think maybe during the transition of menopause, and it was because of vasomotor symptoms, not because bioidentical progesterone upregulates GABA receptors in your brain, and the GABA receptors help you sleep. They also calm you down. They decrease anxiety. They didn't bother to mention that. Oh, folks. Now they talk about skin, hair, and special senses. Estrogen therapy may benefit wound healing, through modifying inflammation, stimulating granulation, tissue formation, and accelerating reepithelialization. Estrogen therapy increased epidermal and dermal thickness, increased collagen and elastin content, and improved skin moisture. This is why those garbage companies out there are marketing estriol creams to you for $100, because we know that estrogen, but I would say specifically estradiol, which is about 100 times stronger. If you have good estradiol levels in your blood, you will have increased dermal thickness, increased collagen and elastin content, improved skin moisture, and fewer wrinkles. You don't need the creams, ladies. You need it in your bloodstream. So let's not waste money on the topical creams, which I have already talked about. I think they're garbage. If you have adequate blood levels, you don't need the cream. Sorry, I had to take a drink. I'm making myself thirsty. All right. Key points with estrogen and skin from the NAMS statement. Estrogen therapy appears to have beneficial effects on skin thickness, elasticity, and collagen when given at menopause. That's great. I think that's awesome. Changes in hair density and female pattern hair loss worsen after menopause, but research is lacking regarding a role for hormone therapy. Come on, man. If you know it happens after menopause, and we know what happens during menopause is the hormones drop, what's the thing? Okay, I can tell you what's happening. Testosterone stimulates hair follicle growth. Okay, well, when you go through menopause, your testosterone is going to drop by at least 50% because the ovaries make about 50% of your body's testosterone. Estrogen. When estrogen goes down, we know that the skin thins out. It changes elasticity and collagen levels. Hair is part of the skin. And then progesterone. When is the best time of your life for your hair? Is when you're pregnant. And it's because progesterone stops hair growth in the cycle called the telogen phase, which is right before your hair falls out. So progesterone will slow hair loss. That's why after you deliver a baby, all your hair falls out, because your progesterone drops. All right. Hormone therapy and quality of life. Okay. And this is literally one paragraph, because quality of life, well, that doesn't matter. Quality of life, and they defined it, is defined as an overall assessment of one's life in relationship to goals and expectations. Quality of life can be applied to one's mental and physical health, which is termed health-related quality of life, or specifically to menopause or menopause-specific quality of life. Man, I don't think I could read that twice. Which emphasizes the bother and interferences of menopause symptoms. Key points here is that menopause symptoms are associated with poor health-related and menopause-specific quality of life. No shit. Systemic hormone therapy can improve menopause-specific quality of life. No shit. And they talk about osteoporosis, which we know. Now let's look at joint pain, because how many women that go through menopause have joint pain? Direct binding of estrogen to estrogen receptors acts on joint tissues, protecting their biomechanical structure and function and maintaining overall joint health. But the exact effect of estrogen on osteoarthritis remains controversial. There is no clearly observed association between hormone therapy use and osteoarthritis. Okay, osteoarthritis, but we know that many women that have joint pain, muscle pain, how many of you are out there that were menopausal, that were started on hormones, your muscle and joint pain got better. And they refer to this in the first sentence, that estrogen binds to the estrogen receptors on joint tissues, protecting their biomechanical structure and function. Okay, great. Why can't we just leave it at that? Why do we then have to say there's no observed association between hormone therapy use and osteoarthritis? Because physicians are going to read that and they're going to say, oh, you don't have osteoarthritis, so it's not going to help you. Well, it might help you because you might just have plain old joint pain. I'm getting nauseous reading this. Then we talk about diabetes, metabolic syndrome, meaning you're gaining weight, you're insulin resistant. How many people does that happen to? And body composition. Women receiving, again, they only talk about combined equine estrogen plus medroxyprogesterone, Prempro. I don't know who the hell prescribes that anymore. Had a statistically significant 19% reduction in the incidence of type 2 diabetes. 16 fewer cases per 10,000 person years. So basically, we know that if you're in menopause and you go on Prempro, which is trash, you have a 20% reduction in type 2 diabetes. Well, that's pretty damn good, I think. A second smaller meta-analysis confirmed these findings and reported that women with type 2 diabetes who already had the diabetes that used estrogen therapy or estrogen progesterone therapy had better glycemic control, meaning their blood sugars came down. The benefit of the hormone therapy then was reversed if the therapy was discontinued, meaning the diabetes could come back. Heck, that's great because diabetes is a problem and it shortens your lifespan. Weight and body composition, the menopause transition is associated with an increase in body fat and a decrease in lean body mass. We know this. How many women that go through menopause say they gain 10 to 15 pounds around their midsection? Everybody. After controlling for body size, ethnicity, and the average weight gain during, what they found was the average weight gain during midlife and menopause was about 1.5 pounds a year. It's 15 pounds over 10 years. So women who used hormone therapy did not have observable differences in the trajectory of body fat gain. And I would agree with that. I don't necessarily see that when I get hormones back in line that women just shed a bunch of weight. There are a few, but it doesn't usually happen. But it can decrease the incidence of type 2 diabetes. With regard to cognition, small clinical trials support the use of estrogen for cognitive behavioral benefits when initiated immediately after hysterectomy if the ovaries are removed. 3 large studies demonstrated neutral effects of hormone therapy on cognitive function when used in the early postmenopausal period. So the hypothesis is that there's a critical window on the timing of the treatment, and the sooner the better when it comes to cognitive therapy. With Alzheimer's, again, we're only looking at the Women's Health Initiative, really, doubled the risk of dementia. But again, conjugated equine estrogen plus medroxyprogesterone is what was studied when it was initiated after the age of 65. However, just starting estrogen alone did not significantly increase the risk of dementia. So again, there's something with Prempro, horse urine, and medroxyprogesterone. There's something there that increased the risks of breast cancer, that increased the risks of dementia. It's just an overall bad medication. But that doesn't mean you can apply that to the bioidentical hormones. Not even the compounders, but the bioidenticals. Then we look at depression. Depressive symptoms worsen as women transition through menopause. We know this, although evidence is mixed. Well, we know it. Clinical guidelines recommended that clinicians screen for depression in women with a history of depression. Well, I do talk about, mood and things like that at my visits. Estrogen therapy does show some efficacy in the management of depression in midlife women, but it varies by menopause stage. Now, that is also just highly dependent on the patient because, it's depression, and how different are we as people, and the reasons for depression vary. So there is some evidence that estrogen therapy has an antidepressant effect. They figured this out. Estrogen therapy is ineffective as a treatment for depressive disorders in postmenopausal women. However, I would say if you feel like trash, I think that's going to amplify the effects of your depression. If you're tired, if you're hot flashing, if you're irritable, if you're not sleeping, if you have no energy, I think that's going to make you feel worse. So if we get you feeling better, is it not possible that the depression could slightly improve? I think so. Cardiovascular disease and all cause of mortality. Observational data and reanalysis of older studies by age or time since menopause, including the Women's Health Initiative, suggests that for healthy women who are within 10 years of menopause transition and who have bothersome symptoms, the benefits of hormone therapy, estrogen or estrogen progesterone, outweigh the risks with fewer cardiovascular diseases, meaning heart health is better in their statement if you start within 10 years of menopause. We talked about this a little bit earlier. So we do know that if you have a lot of calcifications in your heart, then you are at an increased risk for heart disease in general. And if you use estrogen, it's just the estrogen piece, but if you use estrogen, then there is a potential increased risk that we could soften those calcified plaques, and you could have an increased risk of heart disease. But again, small, and it could improve your quality of life to the point where maybe you start eating better, you're working out more. And I will usually work with these women with a cardiologist or someone of that nature and a nutritionist and all that stuff. So it's not just a one size fits all. The biggie, breast cancer. How many times have you heard somebody say to you, I can't go on hormones because I have an increased family history of breast cancer, or I'm afraid of hormones because of breast cancer, or some woman finds out that you're on hormone therapy and she says, oh my God, you can't go on that, you'll get breast cancer. Just in general, without hormones, breast cancer affects approximately 1 in 8 U.S. women. Okay, that's even without hormone therapy. So it's common, unfortunately. Different types of estrogen and progesterone, as well as different formulations, timing of the initiation, duration of therapy, and patient characteristics may play a role, meaning breast cancer is not one thing. And I will go on the record saying breast cancer is not caused by estrogen. If it was caused by estrogen, then we would all get breast cancer, especially all women, because you all have estrogen. Men have estrogen. Men don't get breast cancer. Usually, it can happen. But if estrogen was the cause, then you'd all get it. So estrogen can't be the cause. Now, if you have an estrogen receptor on a breast cancer cell, then it will stimulate that breast cancer cell to grow. But is it the cause? And again, all they talk about with the breast cancer risk is conjugated equine estrogen plus medroxyprogesterone. There's no mention in here of bioidenticals. However, if we just used estrogen alone compared with women who received a placebo, women in the conjugated equine estrogen arm, which I talked about earlier, had a reduction in breast cancer risk after age of 7.2 years on the therapy, with 7 fewer cases, meaning even on the shitty horse estrogen, women that were on it for 7 years had a lower rate of breast cancer than women who received placebo. To me, this means you should go on estrogen. I mean, that's what it means to me. You should go on estrogen if you're in menopause. Longer durations of use, there really aren't any good studies. The median use that they looked at was 7.2 years. And as I just said, estrogen only, there was a decreased risk of breast cancer. So the attributable risk of breast cancer in women age 63, because that was the mean age in the Women's Health Initiative, women that were 63, not 50, 63. What they found was women that took, remember, when this study came out, everybody stopped their hormones because they were all going to die of breast cancer. Everybody. I can't tell you how many phone calls I got. What they found was even women taking shitty Prempro, which is not what I prescribe, there was less than 1 additional case of breast cancer diagnosed per 1,000 users per year. The risk was slightly less than observed with a daily glass of wine, less than with 2 glasses of wine, and similar with the risks of obesity and low physical activity. I mean, this is ridiculous. And to think of all of the fear that's even instilled in doctors because they won't prescribe hormones. When I just said that the risk of breast cancer in women that used estrogen only was decreased. Completely ridiculous. How about the role or the type of use and the route of administration? Basically, what they found was synthetic progestogens may have more of an adverse effect. Duh. Stop using progestogens. We don't need them. We've got bioidentical progesterone. Basically, they also found that oral and transdermal estrogens appear to have similar effects on the number of breast cancers diagnosed. Vaginal estrogens, there was no increased risk. But they basically then say there was insufficient clinical data. How about hormone therapy after breast cancer? They talk about 2 randomized controlled trials that were reported on conflicting outcomes of breast cancer reoccurrence with hormone therapy. One study, which was called Hormone Replacement Therapy After Breast Cancer, Is It Safe?, showed an elevated risk of breast cancer recurrence in hormone therapy users relative to non-users after 2 years. Whereas another trial, the Stockholm Breast Cancer Study, showed no effect on breast cancer recurrence, and that was at 4 years and basically 11 years, but did show an increased risk of breast cancer in the other breast. Makes no sense, but there you have it. Key points to breast cancer. The risk of breast cancer related to hormone therapy use is low. This is from their statement, with estimates indicating a rare occurrence, less than 1 case per 1,000 women per year of hormone therapy use, or 3 additional cases per 1,000 when used for 5 years. And this was on conjugated equine estrogen and medroxyprogesterone. Women should be counseled about the risks, which I do. The effect of hormone therapy on breast cancer risk may depend on the type of hormone therapy, the duration, and the regimen. Different hormone therapy regimens may not be associated with increased breast density, which may obscure mammograms, leading to mammograms or more breast biopsies. That's true as well. Goes on to talk about endometrial cancers. Endometrial cancer is the most common gynecologic malignancy in the United States, and it stems from unopposed systemic estrogen therapy, meaning if you have a uterus, you should never just use estrogen. You should always use a progesterone with it, because if you just have unopposed estrogen, you have an increased risk of uterine cancer. How about ovarian cancer? Ovarian cancer causes more deaths than any other gynecologic malignancy. Use of oral contraceptives is associated with a reduction in ovarian cancer risk. We know that, which is because it decreases ovulation. Anything that decreases ovulation in women decreases the risks of ovarian cancer. The risks decline with the longer use of birth control pills, with the risk reduction after 1 to 4 years of use, and that lasts for 30 years. So women that are on birth control pills for more than 12 months of their life have a decreased rate of ovarian cancer, and that protection lasts for up to 30 years. Current and recent use of hormone therapy is associated with a statistically significant but small increased risk of ovarian cancer. Basically, it was 1 additional ovarian cancer death in 1,700 to 3,300 hormone therapy users. So very, very small, 0.01% around there. And again, that was seen with Prempro. Prempro's shit. Don't use Prempro. That's the story here. They go around to talk about colorectal cancer. Colorectal cancer is the 3rd most common cancer and the 3rd leading cause of death in U.S. women. We know the risk factors: smoking, obesity, decreased use of screening like colonoscopies and blood in the stool. Observational studies generally support a reduced risk of colorectal cancer in hormone therapy users. So we know that it decreases the risk of colon cancer. End of story. Key points. If you have a family history of colon cancer, you may want to use it. Lung cancer therapy. Lung cancer is the 2nd most common cancer and the leading cause of cancer death in women. Smoking, obviously primary. There is an interaction between hormone therapy and lung cancer because of the way that it aromatizes. But it's a neutral effect on hormone therapy and cancer incidence and survival in lung cancer. Obviously, anybody that goes on hormone therapy should be counseled to stop smoking. I don't know who smokes anymore, but we should be talking about that. Then they go on to talk about the duration of use. What they say is you should use it before the age of 60 or before 10 years of being in menopause. Initiation of hormone therapy in women aged older than 60 or 10 years from menopause has complex risks and requires careful consideration. I think we can blow that a bit out of proportion. They're basically saying that, you're not really probably having hot flashes anymore. And again, they only talk about vasomotor symptoms, but a lot of these women may have osteopenia. They may have issues with osteoporosis, cardiovascular disease. So it's something you need to talk about. Extended use after the age of 65. There is no general rule for stopping systemic hormone therapy in a woman aged 65 years. They basically come out and say that. So the key points. Safety profile of hormone therapy is most favorable when initiated in healthy women aged younger than 60 or within 10 years of menopause onset. So initiation of hormone therapy by menopausal women aged older than 60 requires careful consideration. I have that discussion with my patients. Long-term use of hormone therapy, including women aged older than 60, may be carefully considered in healthy women at a low risk for cardiovascular and breast cancer with persistent vasomotor symptoms or risks of fracture. Factors that should be considered included severity of symptoms, effectiveness of alternative non-hormone interventions, which we'll talk about, and things like that. Hormone therapy does not need to be routinely discussed in women older than 60. So we're basically supposed to just ignore those women, I guess, when they ask, because we don't really need to discuss it. The summary, basically the conclusions. Hormone therapy is the most effective treatment for hot flashes and and vaginal dryness, and has been shown to prevent bone loss and fracture. That's good. Risks of hormone therapy differ for women. Okay, yeah. Depending on type, dose, duration of use, route of administration, timing of initiation, and whether a progestogen, they say, they don't even say the word progesterone, is needed. Treatment should be individualized. Duh. For women aged younger than 60 or within 10 years of menopause onset and without contraindications, the benefits outweigh the risks. Good. For women who initiate hormone therapy more than 10 years or 20 years from menopause onset or aged over 60, the benefit ratio appears less favorable and should be discussed, which I do. For genitourinary symptoms not relieved with non-hormonal therapies, low-dose vaginal estrogen, or other government-approved therapies. I love how they have to put that in there. For this paper, they wanted to appreciate the contributions of the advisory panel and the works of the Board of Trustees on the position statement. The authors, planners, reviewers, and staff who were in position to control and influence the content of this activity were required to disclose any and all financial relationships with any ineligible company within the last 24 months. Any financial relationships that were determined by NAMS to be relevant to the activity have been mitigated, meaning if they had financial relationships and NAMS thought it was okay, they just didn't worry about it. Okay. They go on to list the statement who talked about it, basically just a bunch of people that, are Ivy Leaguers. They talked about how they have the financial disclosures and conflicts of interest. All financial relationships with ineligible companies, but they don't talk about what that means to be ineligible. What does it mean to be an ineligible company? For the advisory panel, 1, 2, 3, 4, 5, 6, 7, 8, 9 reported no financial relationships with ineligible companies. One had a relationship with AMAG Pharmaceutical, Cyanexis, Maine Pharma, which is a supporter of NAMS. One had was on the advisory board of Astellas, Bayer, and Johnson & Johnson, all supporting NAMS. Was a consultant for AbbVie, which is a supporter, Baldem and Pfizer, which is a supporter. One was on the advisory board again for Astellas, Ember, Menogenics, Q Oncology, a consultant for Anch Labs. One reported another consultant for Astellas, Happily Health, Pfizer, Vena Health, and Virtue Health, and one had an advisory board for another for Astellas. Are you getting things here? And Astellas, makes a medication for vasomotor symptoms. Lupin, Pfizer, and is a speaker for Bayer, all of who make a lot of hormonal devices and things like that. They then go on to talk about all the other members. But anyways, let's just suffice to say that a lot of people here were on the dole. Now, let's talk about what NAM says about deciding about hormone therapy use. We did talk about that a little bit. But they do mention non-hormonal therapy statements. So they came out in 2023 in June, and they basically talked about non-hormone therapy. They do, however, state that hormonal therapy remains the most effective treatment for vasomotor symptoms and should be considered for women within 10 years of menopause, which is great. Again, they again only focus on hot flashes, which, I mean, think about it. Are you to reduce menopause research after all of the millions and millions and millions of dollars to reduce that? They needed all these Ivy Leaguers on their advisory panel to say that it helps with hot flashes. I mean, come on, guys, we got to do better than this. The non-hormonal options, basically what they recommended was cognitive behavioral therapy, clinical hypnosis, because it's all in your head, selective serotonin reintake inhibitors, or SNRIs, which are antidepressants, because again, it's all in your head, gabapentin, because it's all in your head, and fezolinetant, oxybutynin, which is for bladder spasms. They talked about stellate ganglion blocks, meditation, basically, supplements and herbal remedies. They don't talk about which ones, cooling techniques, avoiding triggers, exercise, yoga, mindfulness. So they basically recommend pretty much anything you can try. But I like how they basically, the first four things they listed were things that have to do with it just being in your head. Okay. I think I might be done with this part. Suffice it to say, the position statement is somewhat laughable because all they focused on was bone loss and vasomotor symptoms or hot flashes and vaginal symptoms. So you have basically been reduced to hot flashes and vaginal dryness. Now, these quote unquote experts that are out there, many of them are physicians, many of them are board certified gynecologists even, but they really toe the line on the NAMS certification. I don't agree with that. I don't think that you need a NAMS certification to know that estrogen reduces hot flashes or that it reduces vaginal dryness. I think that a monkey knows that. And if that's all we can come up with this certification process, then we are sadly in a bad place in women's health. And I apologize to all of you for that because I think we should be doing a lot better. Next week, I'm going to dive into the funding that NAMS has and some of the past leadership, because 12 years ago, 13 years ago, they used to think their president, Wolf Uchian, came out and basically said that bioidentical hormone replacement therapy was quackery. He literally used that word. And now, all of a sudden, he's written a book on it. He's an expert. And NAMS started supporting bioidentical hormones only when Big Pharmacy started making bioidentical hormones in patches and things like that. So it's amazing how when the money started shifting, the mindset started shifting. And now they support it. But it's also fascinating that they never once talk about testosterone, ever. Testosterone replacement is good for bones. It's good for well-being. It's good for sex drive. It's good for a lot of things. And we just flagrantly ignore it. There is no FDA-approved testosterone replacement therapy for women, but there's over 10 for men. And that's why we have women out there being preyed upon by pellet pushers, injection doctors. And I just got to say, any doctor that talks to you about pellets or injections for any hormones, run as far away as you can, because this is a person who is putting profits over patients. Tune in next week. We're going to dive deeper into NAMS. Have a great one. Thanks for listening.